Thank you, John, for inviting me, and I will take the perspective that limited early stage follicular lymphoma should best be observed only. I have no disclosures to make since I know of no drug company that advocates selling nothing. Here are some of the approaches to therapy for limited stage follicular lymphoma. There's chemotherapy plus radiotherapy, there's chemoimmunotherapy, there's immunotherapy, there's interferon, there's chemoimmunotherapy and radiation, and finally there's radiation. When you review the literature, it's almost virtually all retrospective, certainly not randomized and controlled. The literature is just full of all kinds of anecdotal reports. But I think if you look at the review articles on this, the general consensus is that one should receive radiation in some circumstances. Now, they've looked at radiotherapy. They've given limited nodal field radiotherapy, they've given regional radiotherapy, they've given extended field radiotherapy, they've given high-dose radiotherapy, they've given low-dose radiotherapy. However, I advocate no-dose radiotherapy. How prevalent is limited stage? And I'm going to talk about stage 1, although this patient would be theoretically stage 1. I'm going to talk about stage 1 and stage 2 lymphoma. When my very honorable opposition was in swaddling cloth, Dr. Chabner, in 1976, did a study called Sequential Non-Surgical and Surgical Staging of Non-Hodgkin's Lymphoma. Now, this was before the advent of all of our new techniques. This is the era of the lymphangiogram. They put patients through sequential staging, including a staging laparotomy, and they found that only 6% of patients had limited stage lymphoma, follicular lymphoma. Then Dr. Luminari in the Annals of Oncology in 2013 looked at the use of PET in the initial staging of 142 patients with follicular lymphoma. It was a retrospective study from the Fontanelli Italiana Lymphomi, and he found that stage 1 was present only in 2% of patients and stage 2 in 9% of patients. The general consensus is that there's only about 10% of patients have limited stage disease, but in general, few are truly stage 1, despite reports in the literature, because they scour their historical records and they say that they finally found some stage 1 patients. Now, with regard to stage 2 patient, is it really limited disease? Does anyone really believe that follicular lymphoma with an inguinal node and another node in the porta hepatis, although technically stage 2, is limited disease? What type of, quotes, limited radiation would be applied? If viewed as systemic disease, then watchful waiting is considered a perfectly acceptable alternative. These are the results with radiotherapy for the treatment of early stage follicular lymphoma. These are long-term outcomes and they're all retrospective. It is a bit of a complicated slide, but if you look, I've put down the overall survival for 5, 10, and 15, and in one instance, 20 years of follow-up. And on the bottom, I've put down the relapse-free survival. If you will look at 5 years, these patients, all of whom have been treated with radiotherapy except for the bottom 2, that 72% of people in the first study were free of disease. By 10 years, half the patients were only free of disease, and despite the fact that they say that there are very few relapses after 10 years, the relapse-free survival still continues to fall off. My contention is follicular disease is simply not limited disease. It's always disseminated. However, if you say the person lives his lifetime and doesn't have recurrent disease, he's cured, I contend that if every one of us lived to 120, ultimately we would all relapse with follicular lymphoma. In the case of the Wilder study at 15 years, we had a 43% overall survival and a 41 progression-free survival, and on and on and on. Now, if you look down, Dr. Avani had patients who had stage 1 and stage 2, for one reason or another, did not get any treatment. Most of these patients were stage 1 and stage 2. They were all stage 1 and stage 2, predominantly stage 2. And mind you, they did not get any therapy. If you look at the progression-free survival, for instance, at 10 years, you don't see very much difference from those of the patients who received radiation. The only exception is the final study where these patients all had stage 1 disease. At 6 years, they had a 50% progression-free survival. There were really no compelling data to say the treatment really impacts these patients. Furthermore, in a study in the European Journal of Hematology, they looked at what the Flippy score was in these patients with early stage disease. It turns out that almost 90% of them were low risk, and the 10-year survival is 70%. So these data are virtually the same as those reported for limited stage lymphoma to begin with. So what is the bottom line here? The data, almost all retrospective, do not present a compelling argument for therapy in early stage disease. There are little data that radiation is truly curative for the majority of patients with stage 2 disease, particularly those with distant nodal involvement, despite being on the same side of the diaphragm. Observation remains the standard of therapy for disseminated disease, which most of these patients with stage 2 disease probably are. Now, let's see if we can reach some consensus, even though I'm supposed to say there is no therapy. Are some patients cured? As I said before, if by definition remaining free of lymphoma until you die, there is probably a small subset of patients who had stage 1 disease. I have no objection, however, to the judicious administration of local radiation in very limited ports to the area of prior putative stage 1 disease. The question is, are we treating the patient? Are we treating ourselves? And finally, for the majority of patients with stage 2 disease, forget about it. And I thank you for your attention.